Welcome everybody to the January module of the JJ&J Cardiac Surgery Critical Care Academic Program. My name is René Gomes and I'm the coordinator of this program. In January, we're going to tackle A is for anatomy. We're going to focus on cardiac anatomy and cover 4 topics this month. Starting with cardiac and aortic arch anatomy, which is often left out in nursing education. Blood flow through the heart, and then the cardiac cycle. There's a difference between these two. And at the end, we're going to go through coronary arteries. I thought before we even start with the cardiac anatomy, it might be wise just to quickly go through the 3 main functions of the heart so that the anatomy makes a bit more sense. First one is maintaining cardiac output. Our heart needs to be able to respond to whatever our body is going through, and that response will come forth as a rate or perhaps an increase in contractility. For example, if we suddenly have a stress response or exercise, and the reverse in rest. Think about what an increase in body temperature might require from your heart. The second one is ensuring a one-way blood flow. For everything to work properly, blood can't reverse, it can't backflow into your lungs or other organs. It needs to travel in one direction, and we'll go through the valves which are responsible for this. The third one is transmitting blood. Our heart splits into 2 systems. The first one is pulmonary, the right side, the typical blue side that we see in all our diagrams and picture books. This is responsible for oxygenating our blood. Once it's been oxygenated, it comes back to the heart via the other side, which is the left, the systemic side, and that side is responsible for transmitting this oxygen-rich, much-needed blood to all our cells. Okay, so let's have a look at the heart's anatomy. A lot of us have done this in our basic training, and I'm going to combine it with blood flow through the heart as well. So forgive me if you know this, but I think it's a good refresher for all of us. Okay, so let's have a look. Let's start with the superior vena cava, that big vein over there at the top, and the one below coming from the bottom of the heart, the inferior vena cava. These 2 are carrying deoxygenated blood and depositing it into the right atrium. There's the right atrium over there. Within the right atrium, I just want to show you this one structure called the fossa ovalis. It's a rounded structure, and in a normal adult, this is just scar tissue that's left behind after being born. When you're a fetus, you have a natural atrial septal defect that mixes our blood together. Remember, as a fetus, you are receiving blood through an umbilical cord. But once you are born, your pulmonary system kicks in and you take your first breath, and this actually needs to close and divide the heart into those 2 systems which we described before in the functions. Remember, also within the right atrium, we've got a sinoatrial node, and the conduction system starts here. We'll cover that in another module. Okay, so now we've got deoxygenated blood in our right atrium. It needs to travel down to the right ventricle over there. And how does it do that? It goes through a valve. And sometimes it's difficult to remember the tricuspid versus bicuspid. This is the tricuspid valve, an atrioventricular valve between the right atrium and right ventricle. The tricuspid valve is also easier to remember in that we know on the right lung we have 3 lobes. So on the right heart we have 3 leaflets. Not sure what the connection is, but it's an easy way to remember. And on the left side, as opposing, we have 2 lobes on our left lung, and we've got a bicuspid valve sitting on that left side, more commonly known as mitral. Also, a quicker way to remember it is you ride a tricycle before a bicycle. Okay. So we go through the tricuspid valve into the right ventricle. The right ventricle will give a squeeze and the blood will travel forward, remember, one direction only, through the pulmonary semilunar valve. These semilunar valves are designed to not allow backflow. It goes through this valve and into a arterial vein, an artery. How weird is that? That one trips us all up in the beginning, doesn't it? Arteries carrying deoxygenated blood is not common. This is the exception. Remember, arteries, by definition, carry blood away from the heart. It's not actually to do with what's inside, it's just the direction of blood going away. So this is an artery with deoxygenated blood, and it splits into left and right pulmonary arteries. In the lungs, we get oxygenation, and oxygenated, nice, red, beautiful blood comes back to the heart now through a vein. That's very weird, but this is the exception where it's switched around. It comes through 4 pulmonary veins, 2 on the left, 2 on the right, into the left atrium. You can see them over there. Okay, now we're in the left atrium. We have to get to the left ventricle, and please note how thick that left ventricular wall is compared to the right. Remember, this left ventricle, this chamber of our heart, has a very big job to push blood at a high pressure through the aorta to our whole body. Okay, so we go through another valve, and that is the one we mentioned earlier, the bicuspid, also an atrioventricular valve with 2 leaflets, more commonly known as mitral. All right, so through the mitral into the left ventricle. Once the left ventricle ejects and in systole, pushes the blood through the aortic valve into the aorta. Just want to quickly draw your attention back to the valves and just have a look again. Remember, we said these valves look a little like heartstrings at some stage. So they're made of collagen. You can see them over here and here. I'm talking about the atrioventricular ones. Just have a look closer at that structure, and you can see they're made up of chordae tendineae, and that's held together by the papillary muscles, those conical shaped muscles within the ventricles. This is how, if you have an MI, you can end up having a valve replacement as well. It's because these papillary muscles become dysfunctional from being necrotic from the MI and not getting enough perfusion, and that leaflet will go stagnant and the valve won't work anymore. Okay, next up is the aortic arch anatomy. This is the one that I said is often a bit left out. This anatomy is very useful to understand when it comes to ECMO, especially VA and the mixing cloud, which we will get to eventually towards the end of the year. Also, looking after patients with a balloon pump. This is important to understand why some of the nursing observations are so critical when using that device. Also, obviously, it's very applicable in aneurysmal surgery. Okay, so let's have a look just at the aorta. You can see it looks a little bit like Bo Peep's cane. Let's start at the aortic valve there at the bottom. You can see there is the aortic valve, and the first 2 arteries that come off the aorta, if you're going in that direction of the blood flow, is the right coronary artery and the left coronary artery. And all our coronary arteries come off these 2. There's only 2 coming off the aorta. As we carry on up the ascending aorta, the beginning of this arch, we get to 3 main arteries. And these are the ones that are so important when looking after patients with those aforementioned devices. The first one is brachiocephalic, and this is self-explanatory. Brachial, so it's something to do with your arms, and cephalic, something to do with your head. This has also got another name which is more common in the medical world, and that is the innominate. So if you hear innominate artery, it's the same as the brachiocephalic. That first brachiocephalic splits into 2, and that splits into your right subclavian and your right carotid. So your right arm and the right side of your brain. It's all supplied by this artery called the brachiocephalic. The next one is left common carotid artery. So just the left side of your brain has its own artery there in the middle, and that's for the left side of your brain. The last one of the 3 is the left subclavian artery. It branches out into different things, but it's called the left subclavian. So you can imagine when doing nursing observations, perhaps of a balloon pump, why it's so important to compare the right radial and the left radial pulse. Because if your balloon pump is too high and is blocking off that left subclavian artery, it's going to be weakened, and you can immediately tell that something is occluding there, and you know your patient has a balloon pump. You'll then order an x-ray and confirm it on x-ray. But these are the observations that lead to these very important clinical outcomes for your patient. Also, neurological observations. There's 2 different arteries for the 2 different sides of your brain. If you've got ECMO mixing cloud that's too high or too low, or something going on there with the balloon pump, you'll also notice the difference in the pupil size and neurological observations of the 2 sides of the body. Okay, once we've passed those 3 arteries, we start heading towards the descending aorta. And there it splits further into many other arteries that supply the body, such as mesenteric, your renals, your femoral arteries. All very important when looking after balloon pumps and many other devices. Okay, so let's talk about the cardiac cycle. Many people think that they know the cardiac cycle, but what they actually know is the blood flow through the heart. Remember, blood flow through the heart is where the blood is going, where cardiac cycle is how is the blood flow working. So because it is a cycle, it's difficult to find a starting point. So let's start in diastole. Remember, diastole means relaxation, and we're talking about ventricular diastole. So at this point, all 4 valves are shut. Okay, the heart is relaxing, not much electrical activity going on whatsoever, and the blood from the body is returning to the heart from the IVC and SVC, filling up our right atrium. On the left side, we've got the left pulmonary veins filling up the left atrium, and this is happening in a passive way. As the volume increases in the 2 atriums, the pressure increases as well. And as the pressure increases and exceeds the pressure that's in the empty ventricles, those atrioventricular valves are going to open. Once the valves open, we're in the late part of diastole, and the blood flows naturally in a passive way from the atria to the ventricles. The ventricles continue to fill, and we get an end diastolic volume. In this phase of just passively blood flowing from the atria to the ventricle, we can reach almost 80% of our end diastolic volume. For the last bit, we need the next phase, which is atrial systole. Now our ECG comes into play as well, and our electrical system kicks in. So the SA node will fire and the electricity will go through both atriums, causing the atriums to contract and empty into the ventricles through our 2 cuspid valves, tri and bicuspid valves, our atrioventricular. And the last 20% of our end diastolic volume will be ejected into our ventricles. Remember, end diastolic volume is a very special term, and a very special word that will keep coming up is preload, and they are interchangeable. Preload is the amount of volume in our ventricles before they eject. This is very important in our cardiac surgery. We're going to discuss it further in our cardiac output module. Okay, so our ventricles are full, our atria start having less pressure than the ventricles, and what do you think will happen? The valves are going to snap shut. This is very important to ensure that the blood flows in one direction. Okay, so we've got closed atrioventricular valves, we've got full ventricles, and now we have the electrical system giving us a QRS, causing the ventricles to start contracting. Okay, so the next part of the cardiac cycle is ventricular systole. This is where the ventricles contract. So at this moment, we've got ventricles filling up with volume. They've got some volume in. The atria have started to be less full. And now we have an ECG part. Electrical activity comes, a QRS occurs, and these ventricles start to contract. As they contract, that pressure increases dramatically. And what happens is the atrioventricular valves will snap shut because the pressure in the ventricles is higher than the atria, protecting that blood flow going in one direction. So the atrioventricular valves close, and the aortic and semilunar valves will eventually open once the ventricles have overcome the pressure in the afterload. So on the right side, the right ventricle needs to overcome the pressure in the pulmonary trunk, which is around 10 millimeters of mercury in a normal person. So it needs to go over about 7 is where it starts, and it needs to overcome the 10, and that pulmonary semilunar valve will open, and that right ventricle will inject blood forward into the pulmonary trunk and to the lungs. On the left side, and at the very same time, the left ventricle needs to eject blood through the aortic valve to the aorta. This is a much higher pressure system. Remember, this has to deliver blood to the whole body. So it needs to overcome a pressure of around an average diastolic, which is what? 50, 60, 70 millimeters of mercury in the aorta. This ventricle has to work very hard to overcome that gradient. It has to overcome whatever's in the aorta. And remember, that's what we call afterload. Afterload is the millimeters of mercury, the pressure that exists in the aorta that the left ventricle has to overcome to open up that aortic valve. Eventually this will happen, the aortic valve will open, left ventricle will contract, we have ventricular systole, and the blood is ejected through the aortic valve into the aorta and to the rest of the body. This then completes the cardiac cycle, and we start back in diastole again. We know electrical activity exists, and we have a relaxation phase, and the blood will come back from the body, back through the IVC, SVC to the right atrium. What's important to note here, and I'll talk about it with you in person in our in-service training in the units, but a person with aortic valve stenosis, which is where we have calcification or some sort of reason why that aortic valve doesn't open very well, will need a much higher pressure to open that valve. So things like nitrates, vasodilators are completely contraindicated. If we lower the pressure in that ventricle, it's not going to be able to open the valve and could cause a cardiac arrest in our patients. This is why it is so important that the ICU nurse is present during the sonar or the echo of the heart to find out all these details about what the valves look like, what the pressure is in the pulmonary trunk. If it's very high, if we've got pulmonary hypertension, we're going to have the same issue where that right ventricle is working too hard. If we have an MI, we don't want a high afterload in the aorta because we don't want to increase that workload on the left ventricle. We need to know where the MI is and what the status of the heart is. Cannot be manipulating inotropes without knowing this information. This brings us now to coronary arteries. Having knowledge of the specific coronary arteries and their location is extremely useful for caring for the patient through all phases of MI and ischemia or reperfusion. It changes how we treat the patient. An anterior MI's treatment is very different from a patient that's undergoing a MI of the right coronary artery. Knowing this anatomy and putting it together with ECG analysis, angiogram photos, diagnosis, treatment, and then ultimately potentially surgery will make you a cardiac rock star. Let's have a look at the coronary arteries together. Remember when we did the aortic arch anatomy, we said we've got the ascending aorta coming out the top of the heart. Remember, we're on the outside of the heart now. The muscle itself receives no oxygenated blood from inside, from that cardiac cycle and the pathway of blood through the heart. It's a separate system that supplies itself with rich oxygenated blood. So how does this muscle get it? It's those first two branches that come off the aorta, the left and right coronary artery. They branch out and divide themselves up into all sorts of different arteries. Not everybody has all of these. We're all quite unique. This is very much a generalization. Some patients even have collaterals that have grown in time. But the three main ones that I want you to remember are this left coronary artery and the right. The right supplies the inferior side of your heart, which is generally the right side. So your right atrium, your conduction system, and the right ventricle. The left does the anterior side of the heart, that big pump with the thick muscle. one of the most important sides of the heart that can put you into cardiogenic shock very quickly. That left coronary artery splits into two main sections. The first one comes across like a hand over that left ventricle. You can see it over there. And that artery is called our left anterior descending. The other split on the other side that wraps around the heart and heads towards the posterior side, does lateral and sometimes posterior in some patients, is called the circumflex. So let's just go through those again. We have two coronary arteries coming off the aorta. One is the left, the other is the right. The right supplies the inferior side, the right-hand side of the heart. The left one splits into two. The LAD, left anterior descending, which comes in the front of the heart, supplying the anterior septal side. And another section that it breaks up into is the circumflex, which goes around the back. Those are the three main coronary arteries. If you have an MI in that first section of the left coronary artery before the split, in that first section over there, left coronary artery, that is colloquially called a widowmaker. It's a terrible slang word, but it explains it very well. If you have an occlusion there and we have no perfusion down both of those left arteries, so the left anterior descending is blocked, the circumflex is blocked, your whole left ventricle will stop working and you will ultimately die. It is fatal. So when you hear the words left mainstem or widowmaker coming from ED, you better get your running shoes on because you've got trouble. We've got some more coronary arteries in the mix, but I'll teach them to you on our visits. But we can have a quick look here. Let's look at the left ones. We've got two marginals, M1 and M2, and two diagonals, often named D1 and D2. On the right side, we also have a posterior descending artery, which does the bottom of the heart, and a right marginal. Okay, so we've discussed coronary arteries. Let's discuss coronary veins, something that's very overlooked by all of us all the time. I'm not going to go into too much detail. I just want to bring to your attention one specific area of coronary veins, and that's the coronary sinus. So that's where all the coronary veins meet up generally and form a bigger, thicker vein, basically. This vein then empties the deoxygenated blood from the myocardium itself back into the heart, into the right atrium. So the right atrium collects blood from the IVC, SVC, and through a little hole called an os, the coronary sinus empties that deoxygenated blood from the myocardium. Why I want to tell you about the coronary sinus is because biventricular pacemakers are becoming more and more popular. We see them, the three leads on an X-ray all the time. The atrial lead, the right ventricular lead that we used to, but now we're seeing a left ventricular lead that's going around the back of the heart. And this is where it's inserted. By a very specialized cardiologist, usually an electrophysician, will insert this left ventricular lead through the os, through the sinus, and it will live there forever. What's cool about it is a traditional pacemaker with just a right ventricular lead will leave you with a terrible bundle branch block. So while the pacing will keep you alive, you're kind of augmenting a type of heart failure scenario with this enormous unnatural bundle branch block. But adding a left ventricular lead allows us to deliver electricity to both ventricles, which they call resynchronization therapy. And with special algorithms and timing, you can create a very narrow QRS to occur in a very bad heart failure situation with tremendous results, an improved EF, a much better patient, and that's why it's becoming more popular. So look out for that one. Cardiac anatomy. What you have learned today will be basic knowledge that can be implemented in various applications of different types of equipment that you will encounter as a cardiac surgical nurse. Understanding the physiology of the heart is going to benefit your knowledge, your confidence, and your job satisfaction in so many ways. Here's a little best practice reminder. It is important in intensive care to be precise and specific. Don't write valve replacement alone without writing which valves. It's important to distinguish which valves those are precisely. If it's on the right side or the left side, the treatment is completely different. The same goes for MI. What we spoke about earlier, if it's anterior, it's a completely different treatment to the inferior MI. The I of ICU is for intensive. We need to get all these details right. Be specific when you receive an open heart patient that had a CABG. Write down where exactly the bypasses have occurred and which conduits have been used. All members of the multidisciplinary team should take an interest in this and tailor their care according to these specific diagnoses. And it's important that the ICU sister is the one that facilitates this and is able to convey all this information. Thank you very much for your time and attention. This investment that you've made in yourself and your career and these patients is invaluable, not only to JJ&J, but to you as a practitioner. Hope to see you in the wards soon. If you're not in our region, we'll see you in the next video. Goodbye.